Welcome to this Grassroots Health interview. I'm Jen Aliano, Director of Grassroots Health, and I'm here with Dr. Bruce Hollis, a senior vitamin D researcher who has published many papers specifically on the topic of the safety and effectiveness of vitamin D in prenatal and infant health. Dr. Hollis was Professor of Pediatrics, Biochemistry, and Molecular Biology at South Carolina University Medical Hospital. He has a doctorate in nutritional biochemistry and has published many papers on the subjects of vitamin D in pregnancy, cancer, endocrinology, and other topics. His laboratory has focused on the measurement of vitamin D and its metabolites in biological fluids, and he has played a pivotal role in the development of assays to measure vitamin D and its metabolites. His laboratory's methods have been used over the last 4 decades to conduct hundreds of studies and trials, and their assays for 25-OHD and 125D were the first ones to be cleared for clinical diagnosis work by the FDA in the late 1990s. These tools were used to achieve primary goals of determining vitamin D mode of action in human health, including calcium homeostasis, pregnancy, lactation, and oncology, which all continue into the present day. Today, Dr. Hollis and I will be discussing a paper he co-authored with Rostami et al. In 2018 on the effectiveness of a vitamin D screening and supplementation program for pregnant women. The study by Rostami was designed to determine the safety and effectiveness of different vitamin D protocols given based on baseline vitamin D status during pregnancy. A group of 900 pregnant women were followed without intervention and used as the control group, while 900 other pregnant women were included in the screening and supplementation arm. The vitamin D level at delivery and the rate of prenatal complications was evaluated for all women. Among the women in the non-screening group, 98% of the pregnant women remained deficient or insufficient after standard prenatal supplementation. Only 2% achieved a vitamin D level above 20 nanograms per milliliter by delivery. Vitamin D levels at delivery were significantly lower than in the screening and treatment group at an average of 11 nanograms per milliliter. And none of these women achieved vitamin D levels above 30. For the women in the screening group, 53% achieved a vitamin D level above 20 nanograms per milliliter after supplementation. Rates of preeclampsia, gestational diabetes, and preterm delivery were 60%, 50%, and 40% lower, respectively, than the non-screening group. Vitamin D levels at delivery were significantly higher at 21 nanograms per milliliter. However, only 2.7% achieved vitamin D levels above 30 nanograms per milliliter. They also found that preeclampsia rates increased with lower vitamin D levels. No preeclampsia or gestational diabetes was observed among women who reached vitamin D levels above 30 nanograms per milliliter at delivery. So let's review this study in more detail, including several reasons why these findings are so important. Okay, thank you, Dr. Hollis, for joining us today. I am excited to talk to you about the paper by Rostami et al., and you were a co-author on that paper. Can you tell us a little bit about the study design?
Yes, so I was not really involved at all with the study design of this trial. I came into the picture later as they were trying to get it published, and they were having some issues in publication, and their primary language is not English, so they wanted me to read it and give them some advice, and so that's how I became involved. So the study design, it's not a classical randomized trial. There are strong points and some points that are it's basically a really complicated study design. Okay, they the good part is when you do studies in places like Iran or India or overseas, you have an incredible population of vitamin D deficient individuals. Matter of fact, most of them are vitamin D deficient if you look at the results from this. And so they took advantage of this, and they had a lot of patients. I mean, there was 2,800 patients started in this study at 2 different clinical sites. And one of them, they called, they did follow-up, and the other section were the ones that they intervened on, where they tested them and then looked at their baseline vitamin D levels, 25D levels, and then they divided them into groups and supplemented them with a variety of techniques based on what their circulating levels were. And so it made this study, I mean, I think there was like 8 different supplementation regimes that went between weekly supplementation or monthly supplementation for various periods of time, even injections, okay, vitamin D injections, which are not done in the United States at all. So it was very complicated. It wasn't laid out. I think they try to overcorrect to deal with specific deficiencies when we would know that you can't be that accurate. Okay, you would have these deficiencies. You would give a standard amount. So our going amount now is 4,000 to 6,000 units per day, and which leads me to another about this study, is that they have profound vitamin D deficiency across their population. They can do these studies and leave some of these subjects vitamin D deficient as standard of care because that is their standard of care. Okay, they just leave them be and they go through pregnancy deficient. We can't do that in the United States, of course. And you can't leave them deficient. You have to intervene in some way. And then they divided them in this study into moderate deficiency, which was less than 20 nanograms, or severe deficiency, which was less than 10 nanograms. And then they had about 8 different treatments for various periods of time, from about 12 weeks when these women showed up in the clinic through delivery. And they measured the vitamin D levels on their initial sample, and then I believe they banked the rest of them and then measured their vitamin 25D levels when they delivered. And then they compared them to another group of patients they had, which they didn't follow up. They just watched these women go through pregnancy in basically a vitamin D deficient state. And then they compared everything to with birth outcomes. The other good thing about this study is that these women are captive audiences. So in our culture, our studies, we have to randomize trials. You give a woman a bottle of pills every month, and they take them, and they say they take them, but who knows? And it's intent to treat models, so you can't ever take anybody out because they're not complying. You have to leave them in. And in this study, they are captive audience. They show up. They said, here's your injection, here's your pill, swallow it in front of us. And so, however they're treating these patients, they're getting 100% compliance. We don't come anywhere near that with our studies. So, and that's why I think in these studies such as this, you see such profound different, effects of vitamin D, because you're correcting profound deficiencies to some degree. And that's how, why these results are so stark and really show the effect of vitamin D. And I think it's undeniable, even in this study, which is really complicated. I think if they'd have gone to a simpler study, they would have seen probably more striking results. And they were cutting their sufficiency off at greater than 20 nanograms. Our sufficiency is at least 40. Okay, nobody's Nobody's okay if they're, as far as pregnancy, unless they're greater than 40. These guys are saying 20. Another problem with the study was I wasn't involved in the analysis of the blood that was being done. That was done there on an assay I was unfamiliar with. So I'm not sure that levels, comparable levels from what we do, say our 20 and their 20 are really the same number. Okay, there's no way to know that. But that being said, I don't think it really matters that much, because you know that these women are getting substantial vitamin D supplements in one form or another. And so what you're looking at the end of birth complications are directly due to that supplementation level. So in this particular study, I would look more at the supplementation level than I would at the actual level of vitamin D attained at the end.
Okay. Which in the women who received the supplementation, uh, the study saw great benefit in terms of their vitamin D levels, but not just that, they saw much lower risk of preterm birth, of preeclampsia, and of gestational diabetes, correct? So you could
Yeah,
take all of that into account and say that the purpose of the study was to determine the effectiveness of a vitamin D screening program and supplementation, right? So
yeah.
based on, even though the supplementation regimen wasn't done exactly how you would have done it, and the testing itself wasn't validated the same way that it would have been validated here. Taking everything into consideration, would you say that the overall objective of the study was met in determining that the screening program was successful?
Oh, yeah, absolutely. Okay. I mean, I think it was a success in spite of the complexity of the study. Okay. A less complex study, I think, probably would have given better results. Although these results are really incredible. Okay, you just don't see this type of of results in in studies like this, especially in the studies that we can run. So, and the supplementation clearly had an effect on circulating 25D levels. Not to the absolute level that they might have been, but it clearly they had an effect. But as I look at this, there's a table in here if anybody wants to go look at this, okay? And it's the outcomes, maternal outcomes classified, as table 2, according to study sites and baseline 25D levels. And they're looking at moderate severe deficiency for preeclampsia, for gestational diabetes, preterm delivery, and then overall pregnancy outcomes. And I mean, so it's an odds ratio graph where you have, if the arrow or thing falls to the right of that line, it's harmful. Okay. But if it falls to the left of that line, which is less than 1, it's beneficial. And on that particular graph, it's just absolutely stunning. Okay. To look at everything. Okay. There's, I think, in 1 or 2 places where the error bars might have crossed that 0 point, but the mean didn't. About the protection, it's phenomenal. Okay. Of the protection that vitamin D offered these women. So if you look at this as an organization, uh, um, I don't see how you could ever dismiss this as vitamin D is ineffective. And especially, I've seen other studies like this. The one from India in 2015 by an author called Sablock was basically run kind of the same way. They did supplementation, but they saw, again, basically the same type of results. That was the first time I'd seen it, and then this one came out. The Sablock study was a much more straightforward study than this one was, but the results were very comparable. So when Cochrane reviews come out and say that vitamin D doesn't have any beneficial effects. They're looking at so many bad studies, that you can't possibly have any positive outcomes because of the way they're run, randomized trials. That these studies like this absolutely show that vitamin D is essential. Okay.
Now, in your studies and what Grassroots Health recommends as well, we aim for a vitamin D level of 40 nanograms per milliliter. And in this study, they basically only treated the women who were below 20 with
Mm-hmm.
vitamin D supplementation. What kind of effects do you think would have happened if even the women who were above 20 but below 30 or below 40, what additional benefits do you think could have been seen? Do you think they would have benefited from additional supplementation with vitamin D?
Yeah, if their levels truly were 20, again, I'll come back to the assay. I can't be sure that what they're calling 20 isn't what we might call 40, okay, based on the way that we do analysis. I can't answer that question. All I can say is that however they did it, uh, it had profound effects. Now, I'll go back to a study that I was involved in, a VDART study at Harvard with the asthma, vitamin D asthma, antenatal asthma reduction trial. And there was a paper that we published out of that, and was in clinical journal of clinical investigation. I think it was published in 2016. All right, it was it's typical pregnancy study. Women come in at 12 weeks, get a blood sample. They go on some treatment. In the VDART, it was standard of care 400 or 4,000 units per day for the duration of their pregnancy. And one of the things that we saw in that study was that when they came in that first trimester, a blood sample was drawn, okay, on all women, and then they were plotted. And if you looked at that first draw, which is which would represent first trimester. When we do these studies, we're not dealing in the first trimester. Okay, that's already passed. So any vitamin D deficiency hits that have happened in that first trimester, they're largely probably not repairable, and that could be a lot of things. It could be lung development. So when they broke that data down and they looked at it was preeclampsia, and they plotted preeclampsia in these women there were, I don't know, I'm thinking 600 women, maybe something like that. Anyway, if they plotted that initial 25D level at 12 weeks, which represents lifestyle, okay, whatever those women are doing, okay, supplementing, going in the sun, that's their lifestyle. Okay, that's an observational, but that to me would represent lifestyle. They haven't been treated. That's just what they do. Maybe they're supplementing, who knows what they're doing, but their levels were 40. Well, their levels were all over the place. But in that trial, any woman who had a level of 40 or higher, we saw not a single case of preeclampsia. Now, that graph was in the JCI, and they made us take that out. We pointed that out. Oh no, you can't have that in there, because there should have been, if you looked at that graph on the distribution of patients, there should have been several cases, if it was random, there should have been several cases of preeclampsia out beyond when women exceeded 40 nanograms. The truth is, there wasn't a single one. It was all back on women who were more vitamin D deficient. So from that standpoint, you look at that data, I did a blood analysis on that. And so I would say that any woman who had a blood level of 40 when they conceived, this is a conception vitamin D level, okay, that we didn't see a single case of preeclampsia in that bunch. I mean, there's explanations. Vitamin D has effect on placental implantation, angiogenesis, all sorts of stuff that could be going on. But so that would differ from the study that we're talking about here. But again, that was my 40, and their 20 could be my 40. I don't know.
Could you explain a little bit more about, because if we're trying to say, yes, a vitamin D testing program was effective, but we can't even say that we agree with their testing, um, how can you encourage others to uh, rely, like what do you have to look into to make sure that a study that is testing vitamin D is
Well,
reliable?
Well, in today's, you go get you should validate your testing through DQuas or one of the organizations that you get samples from, and you run them through and you get a report back. I don't have a lab anymore. So, but we did that for a couple of decades. So you get samples sent to you. How do you compare with other labs? There's 100 of them. You get samples from NIST, and they should read this, and so there are ways you can control for that. And in the United States, I don't have a lot of questions about how vitamin D assays are being run. They're all pretty comparable. Excuse me. There might be some differences, but they're all pretty comparable. So, uh, but that being said, even if you're not being tested, okay, any woman, okay, even in your own lifestyle puts you at 40, okay, and you're thinking about being pregnant, or maybe you're already taking that much, uh, um, even if you put them on a 4 to 6 thousand unit supplement, it's not going to hurt them. Okay, your levels aren't going to go too high to impart any kind of harm. Okay, the harm is not getting it. So even without testing, okay, you should be doing it. We had to do all that in our studies way back because the FDA did, are you going to cause harm and blood levels too high? And, nobody's worried about that anymore since natural levels can be up to 100. And we've seldom ever seen that, no matter what we ever did to a subject to get them that high. So, you know, I think the blood testing, it might be nice to know. I don't think that once you put these ladies on a dose of 4,000, Scott Weiss says 6,000 based on his data, that almost everybody's going to be where they're going to have a protective amount of vitamin D in their blood. You're not going to have to, you're not going to be deficient unless you have some genetic disease.
Okay, well, I'll revisit that after I ask a very important question. And if you could just quickly describe some of your past studies to verify the safety of vitamin D, because there are still people who argue that or believe, because of what they were wrongly taught in school, that vitamin D can easily be toxic, and especially for pregnant women. However, one of the findings in the Rostami paper and findings that you and Dr. Wagner have published repeatedly is about the safety of vitamin D for pregnant women. Can you just quickly verify that?
Yeah, I mean, so Wagner and I's first pregnancy study was designed in 2002, 2003, somewhere back there. It's more than 20 years ago now. And it was basically a safety study. And we wanted to know, we calculated that women would need 4,000 units a day to attain a sufficient amount of vitamin D. And the granting agency said, yeah, this is a great grant. We want to fund it, blah, 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 but however, we're afraid about the levels you want to give. And you need to write the FDA and request their permission to do this. And we did. And the FDA said, well, no, we're not going to give you permission unless you write an investigational drug application, which is what drug guys have to do for drugs, not vitamin D. But we ended up 6 months, wrote that things, got an IND number that we had to cite, we had to use them, but we had to follow all the FDA's monitoring, okay? Because they said, well, we want to make sure you're not going to hurt anybody. And so it greatly increased the cost of the study because we continually had data safety monitoring board. We had to continually monitor blood levels, blood calcium, hypercalcemia, hypercalciuria. Uh, the monitoring committee had to constantly look at the data. And we did this through all our studies. And how many times did we actually see hypercalcemia? Never, not a single one. Okay. How many times did we see hypercalciuria, which is a more sensitive indicator? Well, we saw it a couple of times, but it was always due to dehydration. Okay. It was never due to vitamin D. So once you rehydrated these women, their urine calcium came back into line, and it was so. Of all the studies that we looked at, we never saw a significant side effect that was due to high doses of vitamin D or blood levels. I mean, never a blood level out of range. And I think the same would go for Scott Weiss's VDART study and other studies that we are on base. So lactation study, we never saw a single adverse event that we could contribute to quote high vitamin D intake.
Why is there so much confusion though? Especially still after, it's been more than 20 years since you ran your first trial.
Because the resistance of giving vitamin D beyond what the official societies want to admit. I mean, based on the recommendations, okay, of IOM or whatever they call themselves now, and OBGYN pediatrics, they're just. I think that's one of the things that the administrators who are coming into this really need to deal with this. They need to get on board about how safe vitamin D is, and stop with with all this stuff. I mean, are there people with genetic problems with vitamin D metabolism? Yeah, but it's really rare. Okay, so you might run across one here and there, but we never ran across any. So the fear of taking those amounts of vitamin D, I mean, your own data, grassroots, how many adverse events of all the studies and all the intake levels, how many of those people ever reported a bad side effect? Ever one?
We published a paper on kidney stones,
Yeah, well,
which
that's
is one of
not
the main
related. Yeah,
main concerns with taking higher doses of vitamin D. And no, the risk of kidney stones is greater among those who
yeah.
are deficient in vitamin D. And I really love a quote that Dr. Patrick McCullough recently said. There are two types of vitamin D toxicity. And by far, the one that is more harmful is caused by vitamin D deficiency. Um, so I do want to step back a little bit and revisit the topic of screening and testing because, we did a study, Grassroots Health did a study with the Medical University of South Carolina, and we initiated it in 2015. And the purpose was to see what benefit there was of vitamin D screening in I believe, the first trimester, the second trimester, and then right before delivery, with the purpose of supplementing to get the women to a level of at least 40.
Hmm.
And what we found, at least in terms of vitamin D deficiency among these women coming in, 89% of prenatal patients had vitamin D levels below 40, with over 30% having levels below 20 nanograms per milliliter, and 65% of pregnant Black women had a vitamin D level below 20.
Hmm.
Um, so that to me is a case for screening. But then also the study found that for the women who achieved a vitamin D level of at least 40 by delivery, experienced a much greater, around 50% reduced risk of preterm birth. Now, when we set out to prepare for this study, we worked with several insurance companies in South Carolina, and they agreed to cover the testing.
Hmm.
Since the program, I believe it ran for a few years, and at some point, insurance stopped covering the testing. And I'm curious with the high numbers of vitamin D deficiency that we found and the results that came from screening up until delivery. Why do you think insurance companies would stop covering screening?
I,
And what changes can we work on um, to address it? What practical steps can be taken?
uh, well, I think it just people lose interest. Okay, uh, the medical university is where I was, and people lose interest. Or again, the recommendations from the OBGYN Society would come out and say we don't believe it has any impact, and then they run back to their superiors or residents run back and say, what are we doing this for? We're not, they're not I guess I'm saying they're not seeing your results. Okay, I guess the only way that you're going to get this done is if you get in the insurance company's face and say, here's the money you're saving by doing this. Do you care? uh, and as far as screening, again, it's great. A lot of physicians won't do anything without a screen. You want to get vitamin D. Well, I got to see what their blood levels are. But if you're a black woman, your levels are on the floor. Okay, you're really at risk. And so you don't, screening is good, but don't stop that from giving them amount of vitamin D. If they want to do a blood test at some point, great. But I uh, I wouldn't let that get in the way of uh, of a supplementation program. And then you'd look at those women based on their outcomes. But the only way you're gonna the only way you're gonna get around this is if you get in the face of insurance companies and show them this is how much money you're saving by you don't have to treat these results of preeclampsia or preterm birth, how much money you're saving by giving a couple of dollars worth of vitamin D, or running a one or two blood. I mean, you don't need to run. You could run an initial blood test and say, look, they're profoundly deficient, and then put them on 6,000 units a day, and never do another thing to them. Okay, maybe a blood level when they deliver, if you're lucky enough to get one. But you would look at, you'd have to look at the outcomes based more on supplementation, I think, of than you would. But again, in these populations of people, especially African Americans, who are notoriously bad at adhering to protocols, it's just the way it is. I mean, there's all sorts of excuses for that. I've heard them all. You're experimenting on me. I hear Tuskegee. The usual stuff. I mean, we heard this all, and they're just really resistant. And and this just isn't for vitamin D. It's for any sort of intervention that you're doing, and they just don't follow protocol as well as they should. So it's a problem group. I don't know how you'd overcome that, whether as they come into the office and you do away with daily supplementations and you would go to a big bolus. If you see them once a month, a big bolus once, which is not as good, but still, if you look at the Rostami paper, it still seems to be quite effective. Okay, at doing it, and then you're in control of the compliance, which you're not on a daily dose.
So it sounds like there's still benefit to screening. I think it can be a motivating factor for an individual to see, because I can't tell you how many times I hear, oh, I get, 5 minutes of sun on my face and hands. I'm
Yeah, yeah,
good. I get enough sun, because vitamin D is the sunshine vitamin. I live in Southern California. We have available UVB throughout the year, but everybody's inside still in the middle of the day putting on sunscreen. And so I think that maybe one of the misconceptions when it comes to vitamin D is that they're getting enough from the sun and they don't need to supplement. And that's where I think screening can be a really important educational
no,
tool, not just for the individuals, but for the doctors who still believe that too.
no, you're absolutely right. There is benefits to screening if you can get them to do it. Okay, if you can get them to screen, great. I totally agree with it, but it shouldn't be a block of not treating somebody just because they're not going to be screened.
Right, of getting the
We
benefits
know enough.
from
Yeah, we
taking
know.
vitamin D.
And and you're talking about if you're a dark African American or dark skinned individual, the sun or not, it's not going to matter to you. You're
Right.
just not utilizing. Your skin can't utilize that sun.
Yeah. And whether we're looking at the studies from India and or was Rostami again,
Iran.
and their levels are just immensely deficient because they're covering up.
Yeah,
Well, our study at MUSC also found, like I said,
yeah.
65% of
Their patients in Iran would be comparable to our blacks, our people of color.
yeah.
That's they're comparable.
Hmm. And do
And
you feel like that might contribute? Do you feel like vitamin D might contribute to the health disparities that we see
yeah,
between uh,
absolutely. But you
Black
can't.
women and what? Yeah.
Maybe that's yes, absolutely. But you can't study that right now. If
Why?
you because of the way because of the way NIH funds. If you go in and say we're going to study health disparities, and I hate to say this, but if it's not based on racism of the physicians, which they were contributing in the last couple of years, based on some really bad studies, that became the thing. If I went for a grant and say I want to study health disparities in African Americans, and I want to look at it from a standpoint of vitamin D, they're not going to fund that because that's not of in vogue of what the current thing is. Okay, it's the current thing is that it's racism, and the white physicians aren't treating the black patients as well as they should be treated, and that's where all this was going. Now, hopefully, that's going to change because you weren't allowed for years. We were looking at biochemical differences amongst races. You can't look at that right now because that's racist. I mean, it's incredible, but go through a grant organization. I'm telling you where your grant's going to go.
Yeah, it's very unfortunate. Um, and that brings me to my next question. With the new administration that is now in office here in the United States, do you think they might be favorably inclined to take action with vitamin D? And if whether or not that might be the case, what is one thing you would tell them about vitamin D if you had their attention right now?
Well, man, what a problem. I would say it really needs to be looked at in pregnancy seriously. Okay, these recommendations need to go out seriously, where you can have you find results out in 9 months. Okay, it's not over a lifetime. If you want to prevent chronic disease, to really get at the root of this, you have to do fortification, because only highly motivated individuals do supplementation. Let's face it. You have to be really motivated to buy the pills, to take the pills every day. If you're trying to prevent some chronic disease like cancer, it could take decades, lifestyle decades. Okay, and I've been told this over and over. So if you really wanted to have an impact, you'd have to change the food fortification levels. And that is a monstrous task. And I think it's one of the reasons that they never wanted to deal with this, because it would change the food fortification tables from basically nothing, okay, to a meaningful amount, whatever that may be.
What is the likelihood, though, that they would fall back on the recommended daily allowance set by the IOM, and how big of
Well,
a problem is that?
they'd have to ignore that stuff. All that stuff is based on bone, okay, bone homeostasis, not any of the things we're talking about. Okay, if you're looking at it from a standpoint of maintaining bone homeostasis, that is probably okay. Which was initially designed for, was not designed for pregnancy outcomes or immune function or all the other things that we're talking about, which are not uh, endocrine functions of vitamin D. They're paracrine endocrine functions. I've been through this in detail with Eric Berg. Okay, he was astounded because he had no idea. He had no idea about these systems. And I told him that the paracrine endocrine function is basically not recognized by any of these organizations. Okay, so yeah, 20 is fine, and but it's only bone, and so it really doesn't have anything to do with immunity or pregnancy outcomes or anything like that. So somebody would have to have the guts to stand up and say, "We just don't believe you." Okay.
Yeah. Well, hopefully somebody does.
Yeah.
I know we're almost out of time, but one of my favorite facts about vitamin D in pregnancy, you bring up its hormonal actions to regulate calcium for bone health. But during pregnancy is the only time in the lifespan that something different and unique happens with vitamin D, where a pregnant woman will eventually develop vitamin D levels that could be toxic and possibly fatal to a non-pregnant individual.
Yeah.
Um, do you
That
think
was
that probably indicates a very specific
no,
need for vitamin D?
yeah, absolutely. I mean, you go back to, when this was discovered in the 70s, I think somebody got some blood from a pregnant woman, they analyzed it for 125, and they were off the charts. And they said, this is 125 now, not 25. 25 is not really involved in this. So it's 125, which is a hormonal form, which is probably it's one of the most potent steroid hormones known. Okay. And so they said, oh yeah, the explanation for this is really simple. It's because so much calcium mobilization is going on. Well, that was a good explanation. 1979. Okay. It's not an explanation today, because if you could use the elevation of vitamin D as a pregnancy test. Okay. Because as soon as a woman becomes pregnant and the placental implantation occurs, at the very beginning, 125 goes right off the charts. And it's not due to calcium, because that's not going on. Okay. And I've run this past people who are biochemists. I said, there's how do you explain this? I said, we know for a fact that 125 in these women right away goes to, we had normal levels are 30 picograms, 400 picograms, 700 picograms. Okay, off the chart. You just and so what's driving that? Okay, it's coming from maternal kidney. Okay, I know that. It's not coming from the fetus. It's not coming from the placenta. It's coming from maternal kidneys. Okay, so some control point mechanism has been released from that enzyme in the kidneys to go all out and make a ton of this stuff. Number one, why is that? Nobody knows. Okay. The second thing is, how do women survive it? Because if you or I had those levels, you'd be dead. So the body has some protective mechanism not to. I remember doing a study way back for Hoffman LaRoche where they were looking at using 125 as a topical treatment for psoriasis. Okay. And it was somewhat effective. Okay. But some people who have psoriasis actually, the sores bleed. Okay. They get really raw. So if you took the 125 cream and put it on those sores, it would absorb back into the body, and the blood levels of 125 would rise to say 100. And instantly we saw hypercalcemia. Even at 100 picograms from topical applied 125, all blood level of calcium started to rise. So that didn't work out. Okay, they couldn't use it for that. But in a pregnant woman, that's nothing. And their blood levels calcium are totally stable. So it's probably an immune function, developmental function, has nothing to do with calcium.
Would it be safe to assume if a pregnant woman wasn't getting enough vitamin D, whether it was from sunshine, supplements, food, that her body would not have what was necessary to produce those higher amounts of 125, and that could possibly lead to some of the adverse effects that we see?
Probably. I mean, there's the body will still makes it like crazy, but probably not excuse me, to levels that are what they should be.
Yeah.
So,
Bottom line, there's a much greater need for vitamin D in pregnancy it's just not being widely accepted and recognized.
people don't even know it. You know,
Mhm.
I've had, this isn't a common occurrence, but I'll get these. So a lady goes in, has her vitamin, she's pregnant, her vitamin D levels checked. Well, the OB checks the wrong one. All right. He checks 125 and the level comes back, 5 times normal, what the lab is reporting in the normal individual. And these women are frantic. The physician said, stop taking your supplements right now. You're vitamin D toxic. You'll be lucky if you haven't done damage to your infant. And these women are frantic, you know, and I get the emails and I said, no, you're perfectly fine. The guy ordered the wrong test. I said, so they don't know what they're ordering. They don't know what, a lot of them, and the wrong test coming back to a woman like that, and where she could have, told she's had done damage to her fetus. They're frantic. Bad information.
Bad information and still a lot of confusion out there about vitamin D. And I want to end on this because I've spoken with many vitamin D researchers, doctors such as Dr. Leslie Ray Matthews, who gave all of his patients in his hospital. He was a
Mhm.
urgent care surgeon. Gave everybody 50,000 IU vitamin D. And, I asked him at one point, if you could say one thing about vitamin D, what would you say? And he would say, pregnant women, start with the pregnant women, get them all on vitamin D, get them all
Yeah,
sufficient, because then you're going to affect that, not just the baby and the pregnancy, but you could potentially be affecting that child for its lifetime.
yeah.
And so I think one of the main points I hope that we can get across, and please comment on this if you would like, is that obtaining enough vitamin D to get your blood levels up to 40 as soon as possible, preconception, if
Mhm.
possible, as soon as you can, as early in pregnancy, can have immense health benefits. And yes, testing for vitamin D is encouraged because everybody responds to supplementation
Yeah.
differently. You can't guarantee that you're getting enough. However, whether it's due to cost, whether it's due to where you live, the availability of testing, vitamin D supplements are pretty easily available. And so if you can't test and you're pregnant, taking at least that 4 to 6,000 IU a day is safe.
Mhm.
It has been demonstrated to be safe. It is safe for breastfeeding. In fact, that vitamin D3, to get it on a daily basis, you give your baby enough vitamin D if you're
Yeah.
supplementing.
So breastfeeding is at least 6,000, but I don't hesitate to have ladies take 10.
Okay, so maybe
and
even
and you
more.
and yeah, and that's what my own daughter did twice. And everybody has Amazon. You can buy it. You can buy stuff on Amazon whatever you want, come right to your door.
Mhm.
But you have to be somewhat motivated.
Yeah. Testing too, with Grassroots Health, we've got our blood spot test kits
Mhm.
that you can order. They're all over online. Just, I think education is probably the biggest piece right now. And not just the women, but the doctors too. And so if you could just offer up some concluding remarks or comments on what the next practical steps are, what's most important that you think people should take away from this.
uh, well, everybody should be taking 4 to 5,000 units of vitamin D a day. I don't care if you're pregnant, if you're 50 years old or 20 years old or whatever. Okay, that will get your 25D levels up to a fairly good stable level and increase your quality of life, probably decrease infection rates. Uh, I don't know. I saw this. Somebody sent me this podcast. You know who John Bernthal is? He's an actor. Okay, he's been in the Walking Dead, series and other things too. And see, he interviewed this guy. Okay, and this guy turned out to be his brother. who's a very well-known orthopedic oncologist at UCLA, and actually trained with one of my colleagues, John Adams, who I did studies with on immune function at UCLA. And Bernthal, the doctor, his name is Nick Bernthal. He's the MD, brother of this actor, and he said, if somebody's going in for surgery, okay, I don't care what kind of surgery it is, mostly they deal in joints or cancer removal. He says if you're vitamin D deficient, your rates of infection are through the roof. And he says, and the outcomes for an infection under those conditions, your chances of dying in 5 years exceed cancer, heart disease, and everything else if you get these infections post-op. And he says, if you take vitamin D, you will not get these infections.
Yeah, it's pretty phenomenal. And then that's even where when you get into cancer and infections, when aiming for a vitamin D level of at least 50 or 60 could even be of greater benefit.
Yeah, when I went in for my abdominal surgery 2 weeks ago, I said, you guys checking vitamin D levels for, prior to surgery? Huh? What? No, no.
Well, Dr. Hollis, I really appreciate you taking the time today to talk to me about this paper and vitamin D research in general. Hopefully, we can get more people to understand its importance and take the right steps in, whether it's their own health or their patients. But yeah,
Okay.
let's
All
do
right.
this again soon. Thank you
Okay.
again.
All right. Thank you.
All right, have a great day.
Yeah. Bye.